Welcome back to Beyond Well Science. I'm Sheila Hamilton, along with Dr. Robert Cotes, an associate professor at Emory University School of Medicine in the Department of Psychiatry and Behavioral Sciences. Rob completed his residency training at Dartmouth and joined the Emory faculty in 2011. He's medical director of inpatient psychiatry and a big fan of open dialogue. Hi, Rob. Thanks for being with us.
Hi, Sheila. Thanks so much for having me. Great to be on the podcast.
Sure. Would you tell me first how open dialogue has affected you personally?
Absolutely. So I first got acquainted with open dialogue in 2016. And at that point, the Foundation for Excellence in Mental Health Care reached out to us and was interested in setting up open dialogue in Atlanta. So I had the good fortune of learning about open dialogue back then, and it's had a profound effect on me, I think personally and professionally. I think the biggest difference open dialogue has made for me has been on sort of this spirit of transparency that happens, I think, in interactions with the people that I work with, my team members, people in my personal life. I really dislike this idea of behind closed doors conversations, and I think that open dialogue and its transparency really spoke to an openness that I feel like I naturally sort of went with. But that's been one of the big things that's helped with me. Another important facet of open dialogue is tolerance of uncertainty.
Yeah.
And I've often felt that there's a lot that we don't know about some of the experiences that people that we work with have. So having a space where we could voice some of the uncertainty was really important for me.
It's very interesting that you say that, Rob, because my late husband had an experience with an inpatient psychiatric care unit where he was told that he was never going to get better and that he would need to see whatever was happening with his psychological suffering as a disability, and they advised him to stop working and even give up custody of our child. And I was thinking, if they'd implemented open dialogue, none of that would have happened, correct?
Yes. I mean, that sounds like it's a really, unfortunatately, horrible message that
it was.
Get, and that's, I think, really in contradiction to the recovery movement in mental health, and really it's really in contradiction to many of the principles that open dialogue holds. In fact, just before this podcast, I was giving a lecture or facilitating a conversation to some of our medical students and residents on how do you talk to people about what a diagnosis might be. And one of the first things that I mentioned was, you never start out by saying things like, we don't think that you can work again. You know, like the first thing I really tried to communicate to the group was, let's have a spirit of hope. And we also have to communicate that there may be some uncertainty, or there likely is some uncertainty about what we know about what somebody's going through, and that we can't really make assumptions about how it's going to be for somebody in the future.
Yeah, that's exactly right. So how has open dialogue affected your system of care more broadly?
So it started as a small pilot in something called Open Dialogue Atlanta, and we aspire to do open dialogue. We can't say that we do open dialogue in the same way that they do in Tornio, Finland, but it sort of started out small, and it started out mostly with doing network meetings for a group of individuals that were experiencing psychosis in a clinical setting. And then there was also another project that was looking at a group of people with similar experiences that was just sort of more focused on research. So we wanted to be able to implement it for everyone that we were working with, rather than just a small subset of people that were interested in doing research. So that began in 2017. We worked with a lot of families and people at the Center of Concern. Many of these people were experiencing psychosis or some other extreme state for the first time, although it wasn't a first episode sort of program that we had created. And then the second iteration of what we did was implementing open dialogue and its principles in a coordinated specialty care program, specifically for people who are experiencing psychosis for the first time. So there were these implementations in some smaller ways, but I think has affected our system more broadly as well. So I think that one thing that it did was it really brought families sort of back into the healthcare setting here at Grady, which kind of sounds a little bit odd, but we, for some reason, organization, I think, had gotten away from really inviting families to participate, families or other loved ones to participate. And I think that from a broader systems perspective, open dialogue helped to really stimulate more families coming into other parts of the conversation that weren't in sort of just open dialogue services.
And what kind of... Oh, go ahead, Rob. Finish up.
Yeah, I also think that it brought a sort of a sense of kindness and humanism back that sometimes can get lost. I think when people are under intense time pressures and where people are feeling like they're not doing the work that they sort of initially started out to do. So I really feel like it brought sort of the person back. The person sort of became more in the driver's seat. I feel like we have always been sort of a recovery-oriented program and clinic here, but I feel like open dialogue really helped us to live that more fully.
Yeah, and what kind of improvements or not improvements have you seen from people who participated in the program?
So I think the biggest improvements have been people feeling less isolated. I think that sometimes when people experience psychosis for the first time, it can be really frightening, and it can result in a lot of isolation from family or other loved ones. So I think that open dialogue really sort of brought people back together and began having conversations again that we were really hoping that would, the conversations in the network meeting, we really wanted people to be able to have similar conversations outside of the network meeting. So I think overall less isolation, and then I think that more people felt more empowered to make decisions about their own situation. So another thing that I found that we were able to do more working with people in this way than in sort of what we were doing with before is people actually were able to have a much more informed discussion about, deciding to take a medicine or not, or I feel like people had the space to ask questions about it, maybe disagree with it. There was a much more of a conversation. We just had much more time, space, and invited all voices to all sort of come to a decision together.
If you're just joining us, we're talking with Robert Cotes. He's an associate professor at Emory University, and he also has brought open dialogue to Grady. I'm very curious, Rob, because what you've just described sounds like it takes a lot more time, a lot more attention, and a lot more willingness to entertain the unknown. Is that sort of what open dialogue is? Yeah,
so that's a great point. And I have to say, Sheila, I was one of the people that was involved with bringing open dialogue, but it really took a team effort from the administration at Grady, from the administration at Emory, from all the team members that we were working with in order to get this off the ground. I think it took a lot of belief that we could do something a little bit different, and I think it also took a recognition that what we were doing needed to be improved. So there was this sort of sense of accountability that we had to do better, and we were looking to open dialogue to help us with that.
Oh, that's really cool. So what have been some of the other challenges that you've seen in implementing these ideas?
So I think one of the biggest challenges has been that network meetings require two clinicians to be present at the same time. And we developed a model where one of our clinicians was grant funded and where the other clinician would be more doing the direct billing. I think that in some healthcare settings that don't have a capitated system, it could be hard to, because you're really, depending on what sort of setting, it's hard to bill for two people doing the same thing at the same time.
Sure.
So having the second clinician in part was grant funded. So I think just sort of figuring out a way that we could make this work financially and in a sustainable way was really important. I think another one of the challenges was that in our initial implementation of open dialogue, we really focused a lot on the network meeting, and we had people that were just sort of focusing in dialogic practice in the network meeting, and we didn't do a good enough job in bringing in other services like case management or like supported employment and education specialists or like individual therapists into the conversation. And and sort of the network meeting sort of became the primary modality of interacting with people, which was good. But I think that on the other hand, we would have been much better to bring in all of these voices, which would have required training all of these other people in elements of dialogic practice or open dialogue. So during our second implementation of open dialogue in the coordinated specialty care team, we really wanted to make sure that all of the different team members were trained in open dialogue, so we could have all of these other people that were doing important work that was helpful and that was based in research. We could bring in their perspectives, and it would all be consistent with what could happen in a network meeting.
Yeah. Have other psychiatric centers looked to your example at Grady as a potential of what might happen with open dialogue in the U.S.?
Well, there are a number of people who are doing network meetings and who are doing open dialogue, and it's a fairly small community that's growing, and a lot of us are in contact with each other and are sort of comparing notes. So I know that there have been some other implementations of coordinated specialty care sort of combined with network meetings. In New York, for example, in On Track New York, they're looking at that there. But it was important for us that sort of at the core of the team, we really had a team that was an open dialogue team, and we had sort of the core elements of coordinated specialty care that were there as well. So that's one sort of unique ripple, at least that I'm aware of some of the work that we're doing.
And I'm very curious if you could just give me, is your life more fulfilling doing work this way, Rob?
Oh, absolutely. I mean, without a doubt. I think that the work that I get to do in network meetings is easily the most fulfilling work of my week. I get to do a couple network meetings per week. I have other clinical roles and administrative roles and roles in research. But without a doubt, I think that being in the network meeting can be some of the most invigorating, and at the same time, it can be really challenging. But I find it incredibly meaningful, and I look forward to doing the network meetings.
I'm hoping somebody hears this who might be on the verge of burnout and gets really interested in bringing open dialogue to their own practice. Do you have anything else you want to add, Rob?
No, Sheila, I think you make a good point, though. And one of the things that my colleague, Sandy Steingard in Vermont, had been wondering was, what is the impact of open dialogue on the clinicians and on provider burnout? And I think that there's really something there. I think that that working with people in this way is incredibly empowering, of course, for the person at the center of concern, but I think it's also empowering for the people who do the work. And in especially community mental health care settings, burnout is really high, turnover is really high. People are often faced with incredible time pressures, and they're doing things that they might sort of wonder what's the point. But I feel like there's a group of people who for that network meetings really, really resonate with them, and that they can find meaning in their work, and they can find themselves helping other people and sort of come back from the precipice of burnout.
No doubt. Thanks again for being with us. Rob's research and his ability to bring open dialogue to Grady was brought to him and his doctors by the Foundation for Excellence in Mental Health Care. And if you want to become a sustaining member of the foundation, you can click on this link now. Rob, really appreciate your time today. Do you have anything else you want to add before we have to go?
I guess I just wanted to say thank you to the foundation. They've been really instrumental in supporting this work. And, without them, it wouldn't be possible. I think we've been able to provide something different and something helpful to people in a way that we otherwise wouldn't have. And I can only see the open dialogue work that we've been doing here at Grady expand and hopefully touch more people.
Yeah. Rob, thanks again for being with us. Really appreciate your time.
Thanks so much, Sheila.
Okay.
Great to be with you today.
Bye-bye.
Bye.